Well, hi everybody. I'm Dr. Martinez, and I'll be talking about updates and controversies on antiplatelet agents in coronary artery disease. So let me share my first slide. Okay, it's a big topic, and we'll be focusing on dual antiplatelet therapy because a lot of studies have come out recently about dual antiplatelet therapy after PCI and after acute coronary syndrome, such as non-STEMI and STEMI. But you can see in this slide that there's so many trials that have been conducted for the past 2.5 decades. This is from the ESC focused update on antiplatelet therapy in coronary artery disease. Roughly, you can see the antiplatelet medications up here. From up to down is how long the patients were put on dual antiplatelet therapy. The size of the circles refers to how big the trials are. This is from 1996 to 2017. Of course, quite a few trials have come out since 2017, which we'll talk about. But you see this little circle here, ISAR, the ISAR trial in 1996, basically looked at aspirin and ticlopidine, the first published dual antiplatelet, dual antiplatelet study post-PCI versus aspirin and Coumadin, or vitamin K antagonist. And at that point, it was shown that the dual antiplatelet therapy was better in terms of outcomes compared to aspirin and Coumadin. And that started all these trials that came out post-PCI. After ticlopidine, of course, came clopidogrel, which was less adverse events with clopidogrel. And the first large trial for acute coronary syndromes that used aspirin and clopidogrel. And we'll talk about some of these trials in the last few years. But let's talk about, let's start our discussion based on the clinical syndromes. Let's start with non-ST elevation MI. And these are the givens at this point. Not very controversial. Aspirin, 160 to 300 milligrams, chewed or crushed for everybody at the emergency room. A second antiplatelet, a P2Y12 inhibitor, should also be given. It's either ticagrelor, prasugrel, or clopidogrel. And a decision should be made based on the clinical status of the patient for either immediate versus conservative or ischemia-driven approach. An immediate approach for non-STEMI in terms of bringing to the cath lab would be about 4 to 24 hours from the time the patient came into the emergency room. For a conservative or ischemia-driven strategy, ticagrelor and clopidogrel can be given with ticagrelor favored, and we'll talk about the reason for that. G2B3A inhibitors can be considered, but this is often a decision made in the cath lab rather than in the emergency room. Certainly, proton pump inhibitors should be considered for those with a history of or high risk for upper GI bleeding. So let's focus on aspirin for non-STEMI. Maintenance dose is 75 to 100 milligrams daily. Several trials have shown no increased efficacy with higher doses, and certainly with higher doses, you do have higher GI bleeding. Enteric coating may help, but it does not prevent GI bleeding. Patients with a history of aspirin, sensitivity or allergy, you can consider desensitization in consult with an allergy specialist. Of course, oftentimes there is no time for that. If it's an acute coronary syndrome, P2Y12 monotherapy can be considered, in which case the stronger antiplatelet agents are favored over clopidogrel. Or you can substitute aspirin with cilostazol. Lots of East Asian and Japanese studies with cilostazol, but you don't see much in the Western literature. But personally, I use cilostazol in with clopidogrel as a substitute for aspirin without any problems. P2Y12 inhibitors in non-STEMI, all patients should be treated with P2Y12 inhibitors. So in combination with aspirin, this is called the dual antiplatelet therapy, or DAPT. The CURE trial in 2001 was a large trial which showed benefit of adding clopidogrel to aspirin in non-STEMI in terms of CV death, MI, and stroke. A lot of these patients were treated medically at that time, 60% medical, 40% revascularized. You must remember at 2001, the drug-eluting stents had not come on board. We're still in the developmental phase. They came about 1 or 2 years later. Evidence for ticagrelor came with the Plato trial. This was 2009, more than a decade ago. 18,000 patients with acute coronary syndrome, which included conservatively treated patients as well as PCI-treated patients, showed a 16% decrease in combined endpoints compared to clopidogrel in favor of ticagrelor, with no significant difference in major bleed. For prasugrel, the evidence comes in the large Triton TIMI 38 trial, which came out in 2007. Patients who had acute coronary syndrome undergoing PCI. There was a decrease in cardiac endpoints by 19% over clopidogrel, but significantly more bleeding. The net benefit was not seen in patients with prior TIA-CVA, more than 75 years old, or whose weight was less than 60 kilograms. For conservative management in patients who primarily are not being considered for PCI, ticagrelor is favored over clopidogrel. In the Plato sub-study of planned conservative approach, ticagrelor reduced CV death, MI, and stroke by 16% over clopidogrel with no increase in bleeding. If ticagrelor cannot be used, then the guidelines favor clopidogrel. In the Trilogy study comparing prasugrel versus clopidogrel in conservatively treated patients, there was no advantage using prasugrel over clopidogrel, and bleeding was higher with clopidogrel, especially in patients who were more than 75 years of age, despite the use of a lower daily dose, 5 milligrams, compared to the standard 10 milligram dose used in the Triton TIMI trial. For STEMI, it's not all that different. It's still dual antiplatelet therapy with the aspirin, again, the same dose at the emergency room. For planned thrombolytic therapy, clopidogrel is favored over the stronger P2Y12 inhibitors, or ticagrelor or prasugrel. So you load 300 milligrams of clopidogrel plus 75 milligrams daily of aspirin. If primary PCI is considered, ticagrelor or prasugrel is preferred over clopidogrel. Again, this is seen in the advantage was seen in the Plato trial and the Triton TIMI 38 over clopidogrel. Duration of DAPT is usually 12 months. This comes from those previous studies, post-PCI, post-ACS. However, we do know that since the second generation stents came, that there had been a trend towards a decrease in DAPT in non-complicated PCI to 6 months. However, a trial that was conducted came out in 2014, the DAPT trial, sort of threw a monkey wrench over that. This was a large trial, almost 10,000 patients who had drug-eluting stent implantation, who had been successfully treated with 12 months of aspirin and P2Y12 blocker. So 12 months of DAPT using clopidogrel or prasugrel plus aspirin. Then they were randomized to a longer period of DAPT, another 18 months versus just aspirin alone. So DAPT would have been a total of 30 months versus 12 months of DAPT plus aspirin alone. Endpoints were seen to be lower, cardiac and stent thrombosis endpoints were seen lower with DAPT. And the events, reduction of events with the continued DAPT was mostly attributed to a lower rate of MI in the DAPT group. However, moderate or severe bleeding was increased with continued DAPT, 2.5 versus 1.6%. Let's look at the results graphically. So the prolonged DAPT, the 30-month DAPT, kind of P2Y12 inhibitor plus aspirin versus the 12-month DAPT showed a decrease in stent thrombosis, 1%, decrease in MACE, 1.6%, myocardial infarction by itself by 2%. However, as I mentioned, there was an increase in moderate to severe bleed of 1%. Death was not significantly different between both groups. So this was a surprise to show that longer DAPT was preventing MACE in these patients who had had a PCI. So it was, people were a bit of a quandary what to make of this data, because certainly not everybody should have prolonged DAPT. There was a blip in terms of higher bleeding, moderate to severe bleeding. There was it was a double-edged sword, so to speak. Another trial that showed that prolonged DAPT more than 12 months might be beneficial in terms of preventing MACE was the Pegasus TIMI 54 trial. Again, a large trial of more than 20,000 patients with an MI 1 to 3 years earlier. The median was 1.7 years. Randomized to 2 doses of ticagrelor, 90 or 60 milligrams twice daily, or placebo. Placebo would just be aspirin by itself. Primary efficacy endpoint of cardiovascular death, MI, or stroke occurred less often with both doses of ticagrelor. 7.85% for 90 milligram dose, 7.77% for 60 milligram twice daily dose, and 9% for the placebo arm. However, major bleeding was higher in the ticagrelor 90 and 60 milligram groups, 2.6 and 2.3% versus 1% for the placebo. But there was no difference in the rates of fatal or non-fatal intracranial hemorrhage. So what to do with this data? Clearly, prolonging DAPT was preventing some ischemic events, but at the cost of bleeding. And you can see here the benefit of prolongation of DAPT in the Pegasus TIMI 54 in terms of primary endpoint. So who can benefit from long-term DAPT? It's presumed that patients with complex PCI would benefit from long-term DAPT, specifically those who have left main stenting, bifurcation, long lesions with long stents overlapping, saphenous venous grafts, more than three stents implanted, or three lesions treated, or three coronary vessels treated, and chronic total occlusions. Use of older generation DES, which we don't really use anymore, they're not available anymore, or those with prior stent thrombosis or cardiovascular ischemic event within the first 12 months of the APT. And in terms of comorbids, maybe diabetes as a risk factor. This has been looked at actually in terms of a scoring system on who may benefit from a long-term DAPT. You can access this in the ACC website, the DAPT risk calculator, based on the analysis of the DAPT trial. Basically enter patient characteristics and procedure characteristics, and then complete the results. And basically anybody with a score of -2 is at increased bleeding risk and will not benefit from prolonging the APT. And a patient with a risk of 2 or more may benefit, may have a greater ischemic risk and may benefit from prolonging the APT. Now, I'll talk about trials which have come later on, which probably make this a little bit less useful, because we know now that it may not be the APT that patients benefit from, but just prolonging effective antiplatelet therapy. So the recent trials, the ones that have come out in the last 1 to 2 years, have actually used shorter DAPT duration, but they do stop aspirin instead of the P2Y12 inhibitor, so that the very short DAPT duration of 1 to 3 months is followed by P2Y12 inhibitor monotherapy. So the aspirin is dropped off, and this may be the best compromise in terms of preventing ischemic events while keeping bleeding low, incidence of bleeding low. So these trials which have come out in the last 2 years include the global leader study, ticagrelor plus aspirin for 1 month, followed by ticagrelor for a total of 24 months, or clopidogrel and aspirin for 12 months, or ticagrelor plus aspirin for 12 months. This is the design of the trial. It basically all comers, everybody with ACS who had a stent, or patients with stable disease who had a stent. Again, 1 month of aspirin, and then ticagrelor 90 milligrams twice a day for 2 years, versus the typical 1 year clopidogrel aspirin and ticagrelor aspirin, and then after 1 year aspirin as monotherapy. The global leader study showed no significant difference in terms of all-cause death between typical reference 12-month DAPT versus the very short DAPT of 1 month and ticagrelor monotherapy for 2 months. So it was not inferior to our typical 12-month DAPT. And there was also tendency towards less bleeding with the ticagrelor monotherapy, but this was not significant. Other trials supporting a very short DAPT was a STOP-DAP2. This was a Japanese trial. In this particular trial, the experimental arm used just 1 month of DAPT, just 1 month, after which aspirin was dropped and clopidogrel was maintained for 1 year. I think there's an extension of this trial that's still ongoing, versus 12-month DAPT of P2Y12 inhibitor plus aspirin, continued for 1 year. And results were analyzed at 1 year. And you can see that the 1-month DAPT versus in blue versus the 12-month DAPT in red was not significantly different in terms of outcomes of death, MI, definite stent thrombosis, and probable stent thrombosis. These incidents of stent thrombosis occurred during the first month before discontinuing the DAPT. In terms of stroke, no significant difference, but in favor of the 1-month DAPT. But look at this. In terms of TMA major and minor bleeding and BARC 3 or 5 bleeding, significantly less in the 1-month DAPT with P2Y12 monotherapy. Significantly less bleeding with no difference in clinical outcomes. The Smart Choice trial studied almost 3,000 patients undergoing PCI. Most of them had ACS. After 3 months of DAPT, they were randomized to P2Y12 monotherapy for the rest of the year. 76% of this was clopidogrel, 24% was either ticagrelor or prasugrel, versus the usual 12 months of DAPT. So outcomes were looked at in 12 months. And if you look at primary endpoint, combined endpoints of major adverse events, there was no significant difference. If you look at the individual endpoints, no significant difference between the two arms. And post-hoc analysis of death or MI, cardiac death or myocardial infarction, and net clinical and cerebral events, no significant difference between the two. If you look at bleeding, however, we can see that the curves begin to differentiate after the 3 months with in favor of the P2Y12 monotherapy group, the ones that had aspirin dropped off at 3 months, almost reaching significance. And if basically, if you do a landmark analysis after the 3 months, and remember that the first 3 months, the treatment was the same. It was dual antiplatelet therapy, but beyond that, aspirin was dropped off. And again, you can see the curves beginning to separate in favor of the P2Y12 inhibitor group rather than the DAPT group. Another new trial reported in the New England Journal of Medicine, ticagrelor with aspirin or alone in high-risk patients after coronary intervention. These patients in the twilight had to have at least one of these clinical criteria and one of these angiographic criteria in order to qualify for the trial. In this particular trial, both arms had 3 months of dual antiplatelet treatment, ticagrelor plus aspirin, open label. After the 3 months, they were randomized to either ticagrelor by itself or the dual antiplatelet therapy with ticagrelor plus aspirin. And as you can see here, in terms of pre-specified bleeding endpoints, whether by BARC 3 or 4 for TME major criteria, or Gusto moderate or severe, or ISTH major, there was less bleeding in ticagrelor monotherapy compared to the dual antiplatelet therapy. However, with the secondary endpoints of death, MI, or stroke, it made no difference. whether it was dual antiplatelet therapy with ticagrelor or aspirin in red, or ticagrelor by itself after 3 months. Same ischemic and outcomes. The TICO trial, ticagrelor, again, with or without aspirin in acute coronary syndromes, was reported last year, ACC. Here you can see that they did enroll quite a bit of acute coronary syndrome patients. Majority are acute coronary syndrome patients, about more than 70%. If you look at the primary outcome, which basically was net adverse clinical events, so this would be the cardiac outcomes plus bleeding, okay, with bleeding, major bleeding being considered a bad outcome. And you can see that within about 3-4 months, the curves separate in favor of the ticagrelor monotherapy after 3 months of DAPT, 3.9% versus 5.9% in terms of the net adverse clinical outcomes. This was significant. You do landmark analysis, which means that the 3 months after the 3 months of same therapy of the APT, and then it becomes monotherapy with ticagrelor, you see a distinct difference, a separation of both curves in favor of monotherapy with ticagrelor. Okay, something that comes up quickly, and now save the slide for this. Coronary artery disease patients requiring combined anticoagulant and antiplatelet therapy. This often comes up in patients, clinically, in patients who are on anticoagulant for atrial fibrillation, who undergo PCI, or develop acute coronary syndromes and have to be loaded with dual antiplatelet therapy. There have been several trials that have looked into this, but the clearest outcomes were shown by the Augustus trial, which was published 2 years ago. Clearly, the new oral antiplatelet anticoagulant, the NOACs, are preferred over vitamin K antagonists such as Coumadin, because of less rates of bleeding in these patients who have to be put on dual or single antiplatelet therapy. So NOAC should be used, should be preferred. If they have been previously stable on vitamin K antagonists, you could perhaps elect to continue, but keep the INR low at lower therapeutic range, 2 to 2.5. And in these patients who have to be maintained on the anticoagulant, clopidogrel is preferred clearly over ticagrelor and prasugrel, which are stronger antiplatelet agents. So use clopidogrel. Aspirin can be dropped off after the index hospitalization. You can stop this when the patient goes home, so you can load it up when the patient has his PCI and when they have their acute coronary syndrome. But in most cases, this can be stopped. So it's a single antiplatelet plus NOAC, which is preferred. You can elect to use aspirin for 1 month at the most in the patients with highest ischemic burden. But when you drop this off, you can continue the NOAC and the P2Y12 inhibitor for 12 months, after which you can consider actually stopping the P2Y12 inhibitor, continuing NOAC alone, or in patients with the highest ischemic burden, you can consider continuing your P2Y12 inhibitor on top of the NOAC. A study called AFIRE, recently published, looked into this, whether you can actually continue NOAC monotherapy, or is it better to have a single antiplatelet in combination with NOAC in patients who have had PCI or bypass surgery or acute coronary syndromes? So we randomized 2,200 patients with a previous history of PCI or bypass surgery a year earlier, and randomized them to rivaroxaban 10 or 15 milligrams a day. Usually this is the dose used in Japanese patients where this trial was done, or versus combination of rivaroxaban 10 or 15 plus aspirin or clopidogrel 50 or 75 milligrams, or prasugrel 2.5 or 3.75 milligrams per day. This is the dose of prasugrel used in Japan. It's a much lower dose than what was used in Triton study, which was 10 milligrams. Surprisingly, patients who were put on monotherapy, just rivaroxaban alone, after 1 year after PCI or bypass, did better in terms of combined endpoints. These are ischemic endpoints compared to combination of rivaroxaban plus one antiplatelet. Kind of hard to think why that would be, but that was what they came up with. As would be expected in terms of the primary safety events, which is major bleed, monotherapy with rivaroxaban did better compared to combination of rivaroxaban plus aspirin alone. So it does seem that after a year of combining NOAC with antiplatelet therapy in patients who require NOAC for anticoagulation for atrial fibrillation and who subsequently develop acute coronary syndromes, or have to have a stent, that you could stop the antiplatelet medication after 1 year and just consider continuing with NOAC alone at therapeutic doses. Okay, so here's my last slide. Again, in patients who have had acute coronary syndromes or have had PCI, the overall duration and type of antiplatelet therapy should be individualized depending on patient characteristics. And the main factors to consider would be whether they had acute coronary syndrome versus PCI for a stable angina or stable CAD, and lesion characteristics, very complicated stenting like left main or bifurcation stenting with 2 stents, long stented areas, etc. Are considered at higher risk in terms of stent thrombosis. Patients' risk for bleeding is a main consideration. Increasingly, though, instead of considering longer-term DAPT for these high-risk patients for ischemic events, a shorter DAPT dual antiplatelet therapy duration of 1 to 3 months, followed by P2Y12 inhibitor monotherapy, appears to provide the best benefit for patients with regards to prevention of clinical events and moderate to major bleed. So one should consider, especially in patients with high risk for bleeding, and also with patients who you might consider to be at high risk for ischemic events later, to stop aspirin after 1 to 3 months. Continue the P2Y12 inhibitor. If it's ticagrelor, you can continue it for 12 months. And maybe replace the ticagrelor with clopidogrel if cost is an issue. Or if you choose clopidogrel as the P2Y12 inhibitor, to continue it for 12 months at least, and beyond 12 months if the patient is high ischemic risk in the future. So that's my last slide, and thank you very much for listening up to this point.
Thank you, Dr. Martinez, for that very extensive and hard lecture. But you managed to breeze through all of the trials, and we thank you for that. First question, sir, in the global leaders and STOP-DAP2 trial, were the patients and the procedure factors considered, meaning were the patients less sick or the procedures less complex? That's why they were able to do a short or a very short dual antiplatelet.
Hi, good morning. Can you hear me?
Yes, we can hear you, sir.
As far as we know, the both trials enrolled patients, all comers, no patients who were either required PCI for stable angina or who had to have it because of acute coronary syndrome. So all these patients were enrolled. If there were any selection in terms of the bias in terms of the procedure itself, we don't know, no? But I believe in both trials, even left main and bifurcation patients were included.
Okay, a follow-up question to this, sir, is that are we ready to accept a very short or a short dual antiplatelet for our patients here, our local patients here who undergo intervention?
Yes, I think if you know, many of the studies, I'll tell you in terms of the DAPT trial, which was in 2014, this DAPT trial still enrolled some patients, many patients who were on the first generation stents, first generation DES. Basically, we don't even have those stents available, even if you wanted to use them. No, we basically using second and third generation stents. And so in terms of stent thrombosis, significantly, this has come down. Stent thrombosis and even to a large extent restenosis. So the DAP population is a little bit different now compared to our current use, our current situation where we're using all new generation stents. So yes, I think you can be pretty comfortable with even just 3 months of the APT if you're not comfortable with 1 month. And for example, elective stenting and dropping off the aspirin. In my clinical practice, it's aspirin I drop off all the time. Even after, if I consider 12 months of the APT, I continue the P2Y12 and then probably taper it off over the next few years. So yeah, 3 months for the newer stents, no problem. If it's acute coronary syndrome, you probably can continue to 6 months, which the guidelines say 6 months, and then drop off the aspirin. I would not stop the P2Y12. Aspirin is what I stop in my clinical practice.
Okay, thank you, sir. Also, what is the recommended scoring system to use in deciding whether to go short, very short DAP or long-term DAP? Is it still applicable? You said there's a changing situation with the newer stents being available and better techniques.
Right. Exactly my response, Melissa. When in the DAPT trial in 2014, the comparator was basically 12 months of the APT, and then you maintain the aspirin.
Mm-hmm.
Whereas the experimental arm continued the P2Y12 with aspirin. And so, you know, as I mentioned, this found a lot of the scoring, which I think is still probably quite useful in the sense of knowing which people, both from the patient characteristics like diabetes or the lesion and intervention characteristics like left main or bifurcation, where you might want a more intense antiplatelet. But for the most part, scoring probably don't need for typical elective PCI. But for acute coronary syndromes, we have to basically do bifurcation or left main or CTO type interventions, you leave the P2Y12
Okay.
indefinitely, and that's a simple decision for me. You can go 12 months DAPT if you want, but don't stop the P2Y12. Stop the aspirin.
Yes, sir. So there's a question also from Dr. Cabreros. When the patient has thrombocytopenia from aspirin, what are your choices in patients who will undergo PCI and have a
Okay.
history of thrombocytopenia?
Yeah, okay. I can answer from the hematologic standpoint, no, in terms of aspirin and thrombocytopenia. But there are two choices. There are two choices. One is to right from the start just use monotherapy with P2Y12
Mhm.
after PCI, either ticagrelor or clopidogrel, and not use aspirin. And that's possible, especially if it's a elective PCI, as the question indicates, in an acute coronary syndrome. The other one that you can use and which I use also quite routinely if I can't use aspirin, is cilostazol.
Oh,
This is not in the guidelines, the big European and American guidelines, because most of the studies, and there are a lot of studies in East Asian population, Japan, Korea, use cilostazol as a second antiplatelet which is quite effective as an antiplatelet agent, and you can use it at 50 to 100 milligrams twice a day.
okay, sir. As a follow-up question, in the AFIRE and the other Japanese trials, they did use lower doses of both antiplatelet and DOACs. Can we do that also among our patients?
So we're talking about the anticoagulation population.
Yes, sir. The anticoagulation population.
The atrial fibrillation with anticoagulation. No? Can we use that during an intense antiplatelet regimen that's necessitated by
PCI.
PCI or ACS? The uh, the reason, okay, the reason in the fire that they used 10 to 20 milligrams or 10 to 15, and this is noted in the study, is that they found that the anticoagulation induced by 20 milligrams was replicated in Japanese population by the 10 to 15 milligram once a day. So whether that translates to a Filipino population, I'm not sure, but I suppose so. No, it's probably based on weight, uh, general size of Asians. So do you go from do you translate that to other NOACs, such as for example apixaban 5 milligrams twice a day, you go down to 2.5 because you have to be on both antiplatelets? That's not answered by these studies, right? But I think that we can replicate we can use the fire in that sense, that to maintain on rivaroxaban 10 or 15 once a day in patients who require a period of antiplatelet therapy. So the short answer is probably yes with rivaroxaban. With other anti NOACs, we don't know. We're not sure, but it's something to consider.
Okay. Just one quick question from Dr. Samuel Versosa. Do you consider doing platelet function assays with all these different antiplatelet to see if there's any resistance?
No, I don't really use that in clinical practice. No, I know it's been there were studies from the Philippine Heart Center that showed that about 10 to 20% of Filipinos were somewhat resistant to clopidogrel based on platelet inhibition trials. I think those are very fine now, etc. But in actual practice, we don't really see a lot of thrombosis, even if you use clopidogrel. Perhaps it's because it's combined with aspirin during the acute portion of the in the first few months. So we don't really use in most cardiologists, interventional cardiologists do not use platelet inhibition testing.
Okay, thank you, sir.